Good morning and welcome to everyone. Our speaker today, we have Sanet Süpra again. She's a clinical pharmacist. Sanet completed her BPharm degree in 2007 at the Northwest University. She went on to complete her postgraduate studies, MSC Med in Clinical Pharmacy in 2016 at the Sefako Makgatho Health Sciences University. Sanet joined Mediclinic Midstream in 2015 as the clinical pharmacist and is currently still based there. She is an active member of South African Society of Clinical Pharmacists and had the privilege to present 2 posters at the 2023 SASOCP conference. Sanet remains a lifelong learner with a passion to improve patient outcomes as part of the multidisciplinary team. Thank you.
Thank you very much. So today it's about a very controversial topic. We know GP goes unpunished to medication prescribed to patients with Myasthenia gravis. Okay, so medications are generally prescribed to improve a patient's health, but there are situations where they can have the opposite effect, either causing harm or worsening an existing illness or condition. And this makes us think a bit more about medication in certain conditions, for example, Myasthenia gravis. Okay, just a brief overview of Myasthenia gravis. This is not at all my area of expertise, so this is the neurologist area of expertise. So just to give a brief overview. So Myasthenia gravis is an autoimmune neuromuscular disorder which is characterized by the presence of antibodies against acetylcholine receptors or proteins of the postsynaptic membrane, resulting in damage to postsynaptic membrane, decreased number of acetylcholine receptors, or blocking of the receptors by the antibodies. Just to make mention of, 85% of Myasthenia gravis patients have autoantibodies against the muscle acetylcholine receptor, where only 5% of them have autoantibodies against the specific muscle-specific kinase. So this is more relevant to the neurologist when they do the treatment of the Myasthenia gravis patients. So the proposed mechanisms of effects of drugs on the neuromuscular junction. So firstly, we look at the nerve action potential blockage. Then secondly, at the blockade of the acetylcholine release. Thirdly, the degradation of acetylcholine and synaptic cleft. And lastly, acetylcholine receptor blockage and inhibition of the muscle action potential production. So as you can see, there's quite an extensive list of drugs that actually impact patients with Myasthenia gravis and can worsen their condition or exacerbate Myasthenia gravis, and eventually some of these medications even leads to a Myasthenia gravis crisis. I'm going to go through all of the medication in a bit more detail. So antibiotics, our first class that is under the red light is the macrolides. In a retrospective study of 212 Myasthenia gravis exacerbations, including 141 hospitalized patients, azithromycin was the most common medication associated with the deterioration of Myasthenia gravis. Exacerbation of Myasthenia gravis has also been reported with erythromycin. Macrolides likely affect the neuromuscular transmission directly. The erythromycin is also reported to cause transient generalized Myasthenia gravis-like symptoms responsive to pyridoxine, even in non-myasthenic patients. This is quite interesting for me. In another report, intravenous azithromycin caused severe Myasthenia gravis exacerbation, which resolved minutes after administration of calcium glycinate, leading to the conclusion that azithromycin blocks the neuromuscular transmission at the presynaptic level. The consensus expert opinion is to avoid macrolides in Myasthenia gravis patients due to acute exacerbation of Myasthenia gravis. The next class is the fluoroquinolones. So the worsening of Myasthenia gravis has been reported after starting ciprofloxacin, norfloxacin, and ofloxacin with a latency of 2 hours up to 5 days. Wang et al. Reported 9 patients that received fluoroquinolones, as you can see, different ones. ciprofloxacin, moxifloxacin, and levofloxacin, developed myasthenia gravis exacerbation and an average increase of 10 points in the qualitative myasthenia gravis score with a latency of 15 minutes after 4 days after starting the drugs. Fluoroquinolones could affect the amplitude of the miniature end-plate potential and current by either a presynaptic or a postsynaptic mechanism. Fluoroquinolones also contains quinoline moiety similar to the quinine, which has also been shown to have a direct effect on acetylcholine receptor ion channels. Expert panel recommend this class drug to be avoided in myasthenia gravis if a safer alternative exists. So unfortunately, if this is the only treatment for that specific infection, you have to outweigh the benefits and the risks and manage the patient accordingly. Then aminoglycosides. So it's also well known to cause myasthenia gravis exacerbation and myasthenia-like symptoms in non-myasthenia gravis patients who are critically ill. When given in high doses in the context of kidney failure or concomitant use of neuromuscular blockers. A study done by Singh et al. Using isolated nerve muscle preparations demonstrated that amikacin had magnesium-like effects on the acetylcholine release from the presynaptic membrane. The blockage was reversed completely by calcium or a 4-aminopyridine and 3,4-diaminopyridine and partially by neostigmine. So we have 3,4-diaminopyridine available in South Africa, but it's very scarce. And there's also a Section 21 options that can be used, but it's not always available. Okay. Gentamicin, when administered in high doses to a critically ill patient, was reported to cause severe neuromuscular transmission disorder responsive to intravenous calcium. Tobramycin, on the other hand, does not cause neuromuscular blockage when used in effective antibacterial concentrations and may be considered as a choice of aminoglycoside antibiotic in a setting that aminoglycoside-associated neuromuscular blockage may occur. Okay, so luckily there are some safe options of antimicrobials. But also there's also a lack of data when we look at the classes. So given the rarity of or lack of reports of adverse drug reactions, cephalosporins, sulfite drugs, clindamycin, tetracyclines, polymyxin B, and nitrofurantoin can be safely administered to myasthenia gravis patients. Penicillin, there's a caution on ampicillin. Although penicillins are generally considered to be safe in myasthenia gravis patients. There are a few reports of myasthenia gravis exacerbations according to Arkov et al. They reported 2 cases of ampicillin-induced myasthenia gravis exacerbations and 1 reoccurrence of the myasthenia gravis symptoms of a challenge with the ampicillin. So given the very widespread use and the limited number of reports of adverse reactions, penicillin should be considered one of the first-line antibiotics to treat infections in myasthenia gravis patients. Antifungals. In a case report described a patient with myasthenia gravis who developed severe ophthalmoplegia after taking voriconazole for aspergillosis. Then the author suggests that voriconazole may block muscle nicotinic acetylcholine receptors and binds to the acetylcholine receptor and reduce the intracellular trafficking of potassium channels. So it's a triple mechanism of blockage. And then there was looking for safe alternatives. There wasn't really data in the echinocandins and limited data in itraconazole. I found one case study where they said a patient with myasthenia gravis and diabetes was treated with itraconazole for damophyte-induced erythroderma, which is also considered as an alternative for the treatment of aspergillosis. We also had a patient that used voriconazole and it exacerbated her myasthenia gravis. So to such an extent, she went in the myasthenia gravis crisis. Okay, then antihypertensive. Belodipine and fidipine were reported to cause significant myasthenia gravis exacerbation. Evaporated after stopping and returned after rechallenging with those medications. In starting verapamil, nifedipine in patients with severe generalized myasthenia gravis resulted in respiratory failure. So I've repeated myself there. In conclusion, myasthenia gravis patients, especially those in remission or well-controlled who need a beta-adreneric or calcium channel receptor blocker, can generally undergo treatment with these medications at the lowest effective dose, but closely monitored, especially initially for the deterioration of myasthenia gravis symptomatology. Then antiarrhythmic drugs. In an early study, Süpra et al. Demonstrated the effect of quinolone derivatives, quinine, quinidine, and chloroquine on both presynaptic and postsynaptic aspects of neuromuscular transmission. Therefore, procainamide has caused myasthenia gravis-like symptoms in even non-myasthenic patients with kidney failure and respiratory failure. In myasthenia gravis patients which do not have a history of respiratory symptoms prior to the use of that medication. So you can see it can very quickly exacerbate them to have respiratory failure. There have been reports of antiarrhythmics such as flecainamide, potassium channel blockers such as amiodarone causing the worsening of symptoms in myasthenia gravis and can be considered as treatment in these patients. Then cholesterol-lowering drugs. Our reported exposure of statins in 54 of 170 myasthenia gravis patients in a single-center retrospective study, which indicates only 11% of statin-treated patients had worsening of myasthenia gravis, usually oculobular, within a period of 1 to 16 weeks of the statin exposure. The weakness was severe in 3 patients in the aforementioned study, necessitating the use of intravenous immunoglobulins. 3 of the 6 patients improved shortly after discontinuations of statins consistent with a causal relation. Roche-Champel et al. Reported in 169 cases of possible statin-induced myasthenia gravis in 3,967 cases of consistent with a 2.66-fold rate-to-odds ratio for statins in relation to the reporting of myasthenia gravis, thus suggesting that statin therapy could increase the likelihood of induction exacerbation of myasthenia gravis. Even due to these studies, the expert opinion suggests that statins are safe in the majority of myasthenia gravis patients, but infrequently may cause exacerbation of myasthenia gravis symptoms and rarely induction of de novo myasthenia gravis, which is a necessity to discontinue. Magnesium. Magnesium causes neuromuscular transmission block at concentrations which do not block muscle contraction to direct stimulation by firstly mainly inhibiting the acetylcholine release at the neuromuscular junction, and secondly, by decreasing sensitivity of the postsynaptic membrane to acetylcholine. Myasthenia gravis has been reported of systemic use of magnesium for preeclampsia and after magnesium replacement during the course of hospitalization in patients with underlying myasthenia gravis, including initial myasthenia gravis manifestations in previously asymptomatic myasthenia. Therefore, magnesium supplementation should be used with extreme caution in patients with myasthenia gravis due to the potential of exacerbation of symptoms, including precipitation of myasthenia gravis crisis. Okay, biphosphonates. Biphosphonates are often used in myasthenia gravis patients due to chronic steroid treatment. Due to the very rare number of myasthenia gravis exacerbation causes of the use of biphosphonates, this class of drugs appears to be safe in myasthenia gravis patients. Okay, then sedatives and analgesics. Myasthenia gravis patients are potentially more sensitive to sedatives and anesthetics. For example, the use of benzodiazepines in myasthenia gravis patients who have significant bulbous symptoms of borderline respiratory reserve could result in a respiratory insufficiency by causing a central respiratory depression and obstruction of the upper airways. High doses of benzodiazepine should preferably be avoided or used with close monitoring of the respiratory status, as such respiratory rate and pulse oximetry. Opioid medications such as fentanyl, buprenorphine, hydromorphine, methadone, morphine, oxycodone, and oxymorphone are commonly used as sedatives and management of acute and chronic pain and are generally well tolerated in patients with myasthenia gravis, although high doses can suppress respiratory function. Fentanyl and propofol have been successfully used in conjunction with non-depolarizing neuromuscular blockers in surgical procedures on myasthenia gravis patients, including during lymphectomy. Korbach et al. Presented a protocol that includes preoperative immunomodulatory treatment, such as IVIG and plasmapheresis, combined with epidural and light general anesthesia, and post-operative epidural narcotic analgesia for 40 myasthenia gravis patients who underwent lymphectomies. Muscle relaxants could be avoided in 13 of the patients, and the mean time of extubation was 9 hours in that study. Okay, neuromuscular blockers and inhalation anesthetics. Succinylcholine is the only depolarization neuromuscular blocker that's available. It is generally avoided in neuromuscular disease, especially those associated with severe lower motor neuron disease, and may cause severe hyperkalemia. However, it's not absolutely contraindicated in myasthenia gravis. Non-depolarizing neuromuscular blockers like rocuronium, mivacronium, bicuronium, and pancuronium causes muscle relaxation by reversible blockage of the acetylcholine receptors without activating it. Myasthenia gravis patients are more sensitive than normal controls to non-depolarizing neuromuscular blockers, and the amount of block can be prolonged and unpredictable. If non-depolarizing neuromuscular blockers are used in myasthenia gravis patients, a lower dose should be used. When we look at the inhaled anesthetics, the different gases, I'm just going to look at cefluorine and isoflurane, which we use in our setting. They also cause neuromuscular blocks, similar to the non-depolarizing neuromuscular blockers in myasthenia gravis patients, and to a less extent in non-myasthenia gravis patients. Okay, antipsychotics. So antipsychotics, fluopromazine was the first typical antipsychotic reported to be associated with myasthenia gravis exacerbation. It was subsequently shown to impair neuromuscular transmission both at the postsynaptic membrane, also to inhibit of acetylcholine release from the presynaptic membrane. Similar dose-dependent effects of the neuromuscular transmission were later demonstrated by Nguyen et al. For atypical antipsychotics, clozapine, olanzapine, sulpiride, and risperidone. So these drugs, and including pyronazide, we don't really use. Clozapine, olanzapine, haloperidol, and quetiapine are long-acting, and risperidone and olanzapine are also reported to cause deterioration of the symptoms of myasthenia gravis patients. So antipsychotics should be used with great caution in myasthenia gravis patients. Then lithium, although we don't see it as often as we used to, it's still used with patients with bipolar disorder. And Pre-Strunk and Druckham demonstrated that lithium causes reduction in the number of acetylcholine receptors in the postsynaptic membrane. So it should also be used with great caution. But as I say again, it will have to be balanced between the disease and the benefit if the patient has both myasthenia gravis and bipolar disorder. Then optic anticonvulsants. So Karen et al. Reported 3 patients with acetylcholine antibodies and myasthenia gravis after treated with carbamazepine, 1 during the treatment and 3 and 13 months after stopping the medication. In the other 2 patients, so it can also look like it induces or exacerbates myasthenia gravis in unknown myasthenia gravis patients. Gabapentin, an antiepileptic which is predominantly used for neuropathic pain, has also been associated with the exacerbation of myasthenia gravis symptoms. Although pregabalin-related interactions has not been reported in myasthenia gravis patients, some recommended caution given the similar mechanism of action to pregabalin. And then Manuel et al. Reported 2 cases of patients with myasthenia gravis who were safely treated with glucosamide. So that's more for focal seizures. So you can use that for patients with epilepsy and myasthenia gravis. And there are no reports. So here we work on adverse drug reaction reporting as a guideline to treat patients with epilepsy and myasthenia gravis. There are no reports on myasthenia gravis-related adverse effects of topiramate, lamotrigine, phenobarbital, and glucosamide, as I've mentioned. Given the rarity or lack of reporting of interactions, we conclude that anti-epileptics are generally safe in myasthenia gravis. So that's why adverse drug reaction reporting is so important for us to create a safety profile for drugs. Then corticosteroids and estrogens. So oral prednisone or prednisolone are now the first line of immunosuppression treatment for ocular and generalized myasthenia gravis. However, higher doses of steroids may result in paroxysmal myasthenia gravis exacerbation or crisis, especially in the first 2 weeks after starting the treatment. The frequency of steroid-induced myasthenia gravis exacerbation has been estimated between 25 to 75%, which is quite a significant amount. As a result, some have recommended starting prednisone at lower doses and gradually increasing the max to a maximum dose. On the other hand, to achieve a faster therapeutic response, some have started high doses of oral intravenous corticosteroids following pre-treatment with plasmapheresis or IVIG therapy. Prednisone zone-induced myasthenia gravis exacerbation is more common in older age, generalized myasthenia gravis with vulgar symptoms, more severe myasthenia gravis, or the presence of pneumoma. And then estrogen increases the susceptibility of mental myasthenia gravis, and myasthenia gravis exacerbation has been reported following hormone treatment and in vitro fertilization. Okay, then when you look at the treatment options, the myasthenia gravis, acetylcholine esterase inhibitors, Beridostigmine is the first line of symptomatic treatment for myasthenia gravis patients. It's generally well tolerated and can be used as monotherapy in milder cases. Beridostigmine prolongs the action of acetylcholine upon postsynaptic acetylcholine receptors through inhibiting the synaptic cleft acetylcholine esterases. On the other hand, beridostigmine may not be effective and even result in deterioration of neuromuscular transmission in the MSC positive myasthenia gravis. Beridostigmine overdose may result in increased weakness and even coronary crisis as characterized by flaccid paralysis and respiratory failure, with the mechanism being desensitization of acetylcholine receptors as a result of sustained elevation of acetylcholine in the synaptic cleft. It has been demonstrated that alterations in the neuromuscular junction after long-term high-dose acetylcholine esterase inhibitors treatment were similar to those induced by myasthenia gravis itself in experimental autoimmune myasthenia gravis. So this also poses quite a risk in patients in treating them, and also at the same time it can harm them with their treatment. Then botulinum toxin. So botulinum toxin A blocks acetylcholine release from the presynaptic membrane, resulting in muscle paralysis. So local botulinum toxin injections for cosmetic purposes may result in weakness in distant muscles and clinical manifestations resembling ocular or generalized myasthenia gravis, or unmasking of underlying subclinical myasthenia gravis, or exacerbation of controlled myasthenia gravis. Then on the other hand, botulinum toxin A has been used successfully in the treatment of cervical dystonia, blepharospasm, and facial dystonic spasms in myasthenia gravis patients without side effects or with transient dysphagia or diplopia. So the experts suggest that the botulinum toxin treatment should be preferably avoided in myasthenia gravis patients, but may be offered with caution to patients with mild, stable myasthenia gravis who also have cervical dystonia or blepharospasms, with gradual titration of the dose and close monitoring. In conclusion, the continued body medication interactions causing exacerbation or worsening of myasthenia gravis emphasizes the importance of careful monitoring and management of drug therapies in patients with myasthenia gravis. Certain medications, including antibiotics, for example, aminoglycosides, calcium channel blockers, and others, can interfere with neuromuscular transmission and may worsen the symptoms of myasthenia by impairing the release of acetylcholine and by directly affecting the neuromuscular junction. Additionally, medications such as anticholinergic drugs, beta blockers, and muscle relaxants can interfere with the delicate balance in the myasthenia gravis patients, leading to the increased weakness or respiratory difficulties. Therefore, it's critical for healthcare providers to assess the potential risk of drug interactions, considering both the direct effect of neuromuscular function and the overall impact on the patient's condition. In conclusion, the management of myasthenia gravis requires vigilance in prescribing medications, closely monitoring patients for signs of exacerbation, and adjusting treatment protocols to minimize the risk of adverse interactions. Collaboration between neurologists and pharmacists is vital to ensure that medications are safe and effective for individuals with myasthenia gravis. Thank you.
Thank you. Yeah. Thank you so much. I think it's really quite a very important topic to know. Most of us, we don't consider it. I think as a clinicians, you're under stress or in casualty, you just prescribe what comes first to your mind. And sometimes that's where complications happen. And I remember an incident in Helen Joseph where somebody got azithromycin and they actually went to cardiac arrest. Obviously, the failure because the monitoring wasn't very good. And And yeah, so that tells you about those drugs that is prescribed on the daily basis, what might actually what can they trigger. And that's really, I think, for me, it's where the problem comes in, but also the same thing, you can predict what's really going to happen. And I think probably during the midst of crisis or myasthenia gravis in ICU critical care, you obviously, I think, for you to go through the list, it's require a bit of, but luckily we have a pharmacist with us always, and that's really a great thing. But I think for those centers without a clinical pharmacist, can be really very challenging, I think. Yeah. So casualty, how do you guys experience it? I know you have a love and hate with myasthenia gravis.
In casualties, my experience is we've only ever seen myasthenia gravis when it's already gone wrong. My experience is myasthenia gravis patients. My one experience is with a patient who has asthma and repeated sinus infections. And I would always say, I remember 8 times documented, 8 times intubating her. But the other times were code blues and other things. So it's not like I didn't store those specifically, but those 8 times, 7 of those 8 times were day 3 after she visited the GP or the pharmacist for sinus medication. So we started making a list. Back then it wasn't computerized. We started having a paper in her pocket with the medications that she had just received from the pharmacist or the GP 3 days ago that has now stopped her from breathing again. So that by the time she came in and her eyes were half closed or she couldn't bend her pinky, we were at the point of just already we knew where we were going.
So are we saying
That's
that perhaps the pharmacist actually must start taking history when the patient comes with prescription?
Oh, for sure. Because the myasthenia patients get irritated or tired of the label. So they have multiple GPs, multiple pharmacists, and then they meet somebody at the brow whose friend is a pharmacist who will quickly give them something to sort out now the sinuses or the asthma. And they treat them. That's how it works.
I think generally awareness for me, before we also had our patients with their exacerbations due to medication, I also we don't really focus on it, we focus on other conditions, but not really on patients with myasthenia gravis. So for me, it was a real eye-opener, and also it cultured the thought of thinking we should actually be creating more awareness among pharmacists and prescribers, because I think on both sides of the coin, and even patients, I mean, some of them do come with their list, which they label as allergies.
You can call it what you want.
It makes it a bit difficult if there isn't an alternative, but I think in a hospital setting you can manage it with supportive therapies. But yeah, I think as you mentioned, they will go for something as simple as over-the-counter medication, and that exacerbates the condition.
So are you saying that actually ideally we should have a database with all this medication, like in the case with the porphyria, where you find that when you go to the website, you got all the medication, likely, less likely, and all those? Do you think we should have that for myasthenia gravis?
So I think the only one I could find available in South Africa is the Myasthenia Gravis South Africa Foundation. So they also have a list. But as I've mentioned, with some of the drugs, some of the patients, they don't react, where others react severely. So it's also, I think, it comes, it's very unpredictable. So it comes only once you experience it from the specific medication that you are now aware and cautious.
Yeah, so I think the message take home is say be cautious when you're prescribing medication for patients with underlying myasthenia gravis, and that will assist you from complications. And I think, anybody online? Do you have anyone